Now, of course, you couldn't hear any of that. Had the mic muted. Once again, this is the Faculty of Podiatric Medicine Journal Club at the Royal College of Physicians and Surgeons, Glasgow. My name is Alan Thompson, and I'm joined this evening by my colleague here, Ewan McGivern.
Hello.
Who is a podiatrist in NHS Greater Glasgow.
And I'm also a MSc student in the Theory of Podiatric Surgery module, Master's Programme between Glasgow Caledonian and Queen Margaret Universities.
Welcome, Ewan.
Thank you.
Can you
Kind of annoying after. Okay, so the article for this evening is the role of fascia in Savinini-Morton syndrome from the Journal of Anatomy. This is published in 2015. It comes from the Journal of Anatomy 2015 by Carla Stecco and colleagues in Italy. And I'd have to admit, Ewan, straight away, Savinini-Morton syndrome is not a term that I'd come across before.
No, I think we all kind of traditionally sort of refer to these things as Morton's or plantar digital neuritis, and Savinini was a name that I hadn't come across until I started to look at plantar digital neuritis as part of one of my master's modules, and it looks like Savinini actually described the manifestation long before Morton did, but Morton's the one who's taken the credit down the years. Of course, if you're a true pedant of the terminology, you'll know that Morton's only occurs in the third, fourth intermetatarsal space, but it's a term that we've now started to use for any plantar digital neuritis, regardless of the location.
Morton's neuroma is certainly something that's commonly seen by podiatrists across the entire country, one of the most common causes of forefoot pain. We're all aware of the various treatments that we can use for Morton's neuroma, but how often do we spend so much time discussing the anatomy of the condition? And this paper does a very good job of that. What were your highlights from the paper?
I think the one thing that sort of struck me was we were starting to look at the dorsal structures potentially involved in some entrapment of the intermetatarsal structures in the neurovascular bundle, because traditionally we're very much thought of plantar structures, and as part of some of the work that I did for the MSc module in anatomy, we looked at treatment options, surgical treatment options for plantar digital neuritis, and very much one of the kind of common themes was a release of the deep transverse metatarsal ligament, which is obviously very much more a deeper structure than this proposed fascia, which extends into the dorsal aspect of the foot. I think we're starting to kind of go back to, in a lot of kind of foot conditions, think about the role of the intrinsic musculature, and this really sort of pulls that in terms of the more sort of plantar intrinsics and how they feed into the dorsal aspect and into the structure as a potential source of this compression.
So in this paper, they had dissection of the foot and embalmed limbs. Was there anything of particular interest to you in the methods that they'd used for the dissection or embalming of the limbs?
I think the first thing that always struck up with a lot of anatomy studies are the number of specimens they had, and they're being relatively low, but that's often going to be the case just for the logistics of cadaveric work. It's interesting that, obviously, again, by restrictions of the specimens that they had, there was no sign that any of these specimens actually had any pathology, so they're really just simply describing the anatomy as opposed to describing any of the kind of the potential pathology that they might see. May have been interesting if they'd been able to sort of repeat with some specimens who had some form of diagnosis of the manifestation of a plantar digital neuritis.
Yeah, so I understand when you're doing your MSc in Theory of Podiatric Surgery, you actually do dissection. So did that give you some appreciation of how difficult some of these studies might actually be to undertake?
Yeah, absolutely. And as a kind of relative sort of novice dissector in the anatomy laboratory, I think you can compare the sort of, how we worked with the specimens with the greatest care in the world that we possibly could, given our level of skill. The skill of these kind of very experienced dissectors is, and to be able to identify a fibrous structure that's essentially around about 1 millimeter thin and be able to preserve that as part of a dissection is really quite impressive. Certainly kind of looked into some of the other work of some of these authors, and the lead author's kind of quite well known for work around about identifying fascial and fascial planes all over the body. And I mean, there's some really beautifully detailed dissections which obviously require an awful lot of skill, which I think anyone who's ever been in a dissection lab would absolutely admire.
Yeah, it's a fascinating insight that you've had into that process, I would say. Looking at the subjects that were involved here, so 11 feet, 7 male, 4 female, mean age 70.9 years old. What particular bearing do you think that would have had on the results, if any?
So, I mean, obviously the age of the specimens is older, but that's to be expected because they came from a body donation program. Really interesting looking at the split in terms of male and female. We certainly know clinically, at least, that probably see a lot more symptomatic neuroma or neuroma-like symptoms in female populations, and probably presenting considerably earlier than these specimens did. Whether there's some atrophy to be had in a specimen that's of that age, I suppose we have to assume that may have been the case. But without being too hard on the authors, they can only work with what they can work with. I think it's kind of reasonable that they took the samples they did actually use.
Indeed, yes, yes. And very grateful anatomists are around the world to those who are willing to leave their body to advance with their science, including here in Glasgow as well. Another branch of this particular study was looking at MRI images of the foot. They did this in 40 patients with 29 controls. And do you have any particular comments on the medical imaging side of this study?
It's interesting, and the authors themselves note the kind of the difference in utility, availability, and cost between use of diagnostic ultrasound and MRI, and certainly something that we've kind of looked at the literature of again as part of some of our master's level work. But I think with the increase in the availability of diagnostic ultrasound, and particularly the kind of some of the really quite encouraging things that are happening in our profession in podiatry around about use of diagnostic ultrasound, MRI is probably becoming slightly more of a hard sell for a lot of these pathologies when they can be so readily, easily, and relatively inexpensively imaged with ultrasound. I think if we skip forward a wee bit to the conclusions that the authors have drawn, that in potential pathological states that the quote that the dorsal fascia should be examined by MRI or ultrasound to ascertain whether it's really altered. It would be interesting to kind of look at the utility of ultrasound versus MRI for that particular purpose, and having had some quite nice exposure to some of the diagnostic ultrasound recently as part of a workshop at the Glasgow Royal Infirmary, the difference in the quality of and the output of some of the ultrasound machines, and just how fantastically detailed some of the new ultrasound machines. You do wonder if in the future that actually gives us more utility to look at these very, very fine and potentially quite complex structures, and the fact that it can be sort of diagnosed in real time and dynamically. I do wonder when they propose MRI as a potential utility, when this is quite a new and novel anatomical manifestation, how readily imaged it will be on MRI. I again sort of reflect on the difference between some of how powerful and how high resolution some MRI machines, and how if there's a potential that there would be more training involved with some of the reporting radiographers or diagnostic radiologists and MSK to identify some of these structures.
Yeah, quite impressive actually. I noticed that recently in NHS Glasgow they'd acquired 2 ultrasound machines for use in the podiatry department, so that's really an interesting avenue for them to be going down at this point. It's although we are seeing that, I think, across NHS Scotland, more and more use of ultrasound in podiatry. I think that's probably worldwide indeed. When you were doing your own studies, one of the things you were looking at was the various treatments. What implications do the findings of this paper have on the treatments, do you think, for Morton's neuroma, if any?
Well, the interesting thing is, if we accept that there's a role of this dorsal fascia to play in the compression, we then start to question whether, there should be, at least surgically, some attempt to release that. And the piece of coursework we were tasked to do as part of the MSc was look at dorsal versus plantar incisions and the potential utility of that. And certainly we kind of came up with there's probably not a huge amount of evidence to support one way over the other. But if we take the Bolam test of what would the majority of surgeons do, they tend to take a dorsal approach, probably around about for reasons of not wanting to cause a plantar scar. And what they may be doing, if we take the role of fascia into account, is by actually doing a dorsal incision and essentially dissecting through this fascia. They're providing even more of a release than they would do simply doing a plantar release. Interesting to compare that with some of the other treatments, whether they're releasing the deep transverse metatarsal ligament. Most surgeons, certainly that I've come across, will probably more likely to do a neudectomy. And some of the literature was looking at some of the slightly more aggressive treatments around about some shortening osteotomies of the lesser metatarsals. But I think if we also look at some of our conservative treatments, one of the things that we relatively regularly do for sort of intrametatarsal pain, whether it's neuroma, bursitis, or other things, is think about injecting into the intrametatarsal space, and probably most commonly with podiatry, certainly in the UK, with the injected corticosteroid. Is there perhaps a role for just simply injecting some fluid into this space and opening up and almost doing a release of the dorsal fascia simply by introducing fluid to it? Is that one of the reasons, as well obviously as the effect of the pharmacology, why we do get a benefit for some of this treatment? Mechanically, and looking at some our even more conservative treatment around about advice for patients on footwear, the use of foot orthosis, how much we're having an effect on the dorsal fascia with that, I'm slightly skeptical of. I think we probably do tend to have more of an effect plantarly, but that's something that would be very difficult to truly quantify in any sort of anatomical study, given how fine this dorsal fascia is.
Thanks, Ian. When you were doing these studies, were you looking at any other papers examining the anatomy in this particular region? And essentially what I was going for there was were the findings similar to what Stecco et al. Found here, or was this at variance to the other literature in this area?
I think the idea of dorsal fascia is probably relatively novel in this paper. I didn't really come across that in anything else that I was kind of looking at. And some of the other studies that we looked at, which are probably around the kind of surgical treatment, was probably more looking at the osseous anatomy around about where we're getting compression, rather than these particularly detailed anatomical studies of the soft tissues in intrametatarsal space.
Hi there. Hi, Emma. We started off with the Google Hangout on the new faculty community page at the Royal College of Physicians and Surgeons Glasgow, and but when we tried to start the Hangout there, it would only allow us to do a direct video call. So we changed it over to a Hangout on air. It's still private at this point, but it will ultimately be published online if it's as long as nobody swears, I suppose. I'm joking. But yeah, thanks for joining us, Emma. Can't hear you. Do you have your mic on mute? I discovered mine was automatically set to mute, but if you move your cursor to the top of the screen, there's a small toolbar that can sometimes interact with. But if not, we'll continue for just now, at least anyway. Was there any other major points that you were keen to discuss? I'm sifting through the article again just now.
And look at it from a pure sort of research methods perspective, and one thing that I just sort of jumped out at me is perhaps a slightly unfair point to make, but was in the statistical analysis, they described these as students' t-test, which is more of a parametric test, and given the size of data they've got, I'm maybe not sure if I wouldn't be looking for some explanation whether the data was parametric or not. And they also use, accepting a p-value of less than 0.05 is statistically significant, or maybe again in some literature seen a move away from that and looking for slightly lower p-values before we describe significance. But again, I don't think we can be too hard on the authors, given it's an anatomical study and the sample size is really quite small.
Yes, granted, it was a small sample. What future direction do you think they would take with this line of inquiry? Any idea there?
Again, I'm going to start with the fact that I'm probably being quite unfair talking about a small sample, because given the availability of cadavers, and actually what I'm sure is a considerable amount of work and skill it must take to dissect and identify structures that are this small. You maybe kind of hope as the discussion moves round about to the imaging, if we're able to kind of skillfully identify some of these structures in the imaging, then perhaps the next stage of a study might be a larger scale imaging study to look at the maybe some sort of mean values in symptomatic and controls.
Yes, I see. I see in the article here they say the future implications research will be to study patients who have no neuroma but who report symptoms suggestive of Morton's metatarsalgia, if I can actually say that. In these patients, the dorsal fascia should be examined by MRI or ultrasound to ascertain whether it's already altered. This may be a predictive sign of foot alteration leading to neuroma if it's not treated properly. As you were alluding to earlier on, the kind of growth in ultrasound and podiatry might make a greater opportunity for examining that kind of area, I suppose. But examining Morton's neuroma with ultrasound is still fairly difficult with the current technology. Emma, have you?
I've tried. Can you hear me now? Sorry. You've gone quiet now. I still can't.
Yes. Sorry, I muted myself because we got the two systems going here at Law College.
Loudly.
How are you, Emma?
I'm very well. I've just had a day of clinical exams, so OSCEs all day, so I'm a bit jaded.
Oh, well, I'm glad that's over for you. Hopefully everybody did very well. So I won't ask you to comment on that, of course. Did you have a chance to have a look at this this paper?
I have just very briefly skimmed it, so I've been very interested listening so far to the discussion, and obviously, some issues of just the practical, feasible side of research in this field are the first sort of hurdles that these authors had to get across. With access to cadavers and the like, but yeah, I think in terms of the power of the study, it almost is feeling like it's it obviously isn't, but it feels almost like it's an enhanced case study because of the sample size and because of the p-values and what have you. That I'm almost tended to look at this through the eyes of this is interesting. I'd like to know more.
Yes, absolutely. It was an interesting paper. Can I just ask on a light note there, Sivanini-Morton syndrome, had you come across that term before?
I haven't. No, I must admit I Googled it.
It's, I asked many colleagues today. None of them had come across that particular term. So poor Mr. Mr. Savanini, was it? Poor Mr. Savanini lost to history there, apparently, despite his initial findings. So we were also talking about the difficulties of doing the dissection earlier, and it's a very small area of the foot to be working on, so that would be quite challenging in itself. The difficulty of imaging in that area as well. There's obviously in the article they were talking about using MRI and ultrasound to supplement their own findings on the cadaver dissection. Ultrasound is something that's increasingly popular. Is that something that you're seeing more of in Plymouth now?
Without a doubt, yeah.
Absolutely. It's a growth area, and the recommendations towards the end of this paper to continue the research using ultrasound, you do think that might be feasible in the future. The latest equipment that's you were saying earlier on, Glasgow just purchased, NHS Glasgow just purchased 2 units to use in practice, and I've had a wee look at them. They're fantastic pieces of equipment. So amazing to think what work will be done even here locally in the future. Did you have any other comments on the paper, Emma?
I'll be honest, I'm literally reading it as we're talking, as well as I've done an initial skim read, but actually to get down to the detail, I'll admit I haven't actually managed to do that yet. But I think one of the interesting things is that obviously there was a lot of preparation of the tissues in the cadaver study, and then they've gone into obviously in vivo as well. So it might even be interesting to see how the preparation of the tissues has influenced their findings, as opposed to the in vivo tissues that have no preparation, are living, breathing, moving tissues.
Absolutely, yeah, that's a good point.
But yeah, apart from that, I'm still very much taking it in, because it's quite a lengthy paper, and it's quite a detailed paper in many good ways. I'm learning lots as I'm reading it. Yes, no, absolutely, and it was a good paper to bring to the Journal Club. Ewan, so if I pass back to Ewan, any other comments you'd like to make at this point?
Apologies if I'm cutting across anything you said, but unfortunately my headphones aren't working, so I've missed anything that you've said. But one thing, just we're talking about the conclusion earlier on, and the author sort of suggesting you're using the imaging predictively. Slightly kind of mindful of the fact that we, until we establish the utility of some of this imaging, how useful it is predictively, and whether we should maybe be slightly cautious of potentially over imaging and looking for pathology that may or may not be there, and how we can have maybe potentially medicalise some sort of normal things. Just I'm kind of mindful of some of the lists around about the lumbar spine, and it's maybe something as we as a profession, as we start to image more, we should be relatively cognizant of. The other thing, again, kind of going back to the role of the interosseous muscles and becoming this fascia. Do we have another potential conservative treatment target for these patients round about how we altered loading patterns and altered function of the intrinsic muscles? Again, I think it's something that we're probably have gone full circle and are using this again clinically a lot more than maybe we did even when I was an undergraduate. And is that something else that we've got that has a role to be used more? I'm not sure. I don't think we've got the evidence for that, but it's interesting to link some of this anatomical studies to some of the other treatments that we may potentially use.
Absolutely, and they were talking about using these findings predictively and examining patients with MRI and ultrasound. The obvious thing there is that there are many causes of metatarsalgia. A term I like to bandy around, and I'll always get in trouble from all my colleagues. They hate the term metatarsalgia. It seems to be loathed universally.
That's the dirty M word.
The dirty M word. It does help me to narrow it down into one particular area. But metatarsalgia, but there are many causes of that. So if you're examining people using medical imaging, and they didn't at that point have any evidence on the imaging of Morton's neuroma. It may well be something else rather than a sort of early stage of that particular condition.
Yeah, I think we have to be kind of really quite mindful of clinical correlation between symptoms and imaging, and not necessarily always kind of going straight to image where we don't need to. But there are, as you say, other causes of lesser forefoot pain, which is as low as I'll deign to call it as a collective term. But are we seeing something else that may not be picked up in imaging that is a potential role in their symptoms? And I've certainly got quite a few patients on my caseload recently who my working clinical diagnosis is just a biomechanical overload of the lesser forefoot, probably around about a dysfunctional first ray, without really any strong clinical signs of anything pathological. And of the couple that have already had imaging, there's nothing to be seen on ultrasound or MRI, because I think simply we are just seeing a biomechanical overload.
Yeah, I think that's a really good point, actually. I don't know if you can hear me. The inference of cause and effect here is quite strong, and yet I think makes a very good point that actually there's a whole lot of anatomy in there, and even though we may find a clinical sign or even a radiological sign, it doesn't necessarily mean that that was the cause of the pain. So I think it would be really good to actually take this study to the next level and start to look at predictive, so use some regression to see if you can find out where the strongest causes were from this study, the likely strongest causes, and then go on to do a predictive study thereafter.
Thanks, Emma. Yeah, you're coming through loud and clear there. We can definitely hear you. Okay, so I'm not sure that I have any other points that I was particularly wanting to raise. I would simply ask you if there's anything else that Emma or Ewan you want to bring to the discussion, or should we wrap up just now?
I don't think I'm going to be able to bring that much more to it.
Yeah, I think we've fairly exhausted a lot of the points I wanted to make in the study, but just take the opportunity to thank you for your help tonight in facilitating this, Alan.
Oh yeah, absolutely, no problem. A pleasure to have your company again, Emma, and thank you very much for bringing that paper to the Journal Club Ewan. We'll put this on the website when we get a chance. It's the good old symposium here at the Royal College this evening, so I expect it'll be busy downstairs for the symposium. So perhaps we can grab ourselves a cup of coffee on the way out. Don't miss an opportunity, I say. So I'll send out information for the next Journal Club as soon as we can. If anyone has any interesting papers they'd like to bring to the Journal Club, then please, of course, get in touch. In order to join in the discussion, you do need to be following the faculty on the Royal College of Physicians and Surgeons Glasgow Google Plus page. There is a community on our Google Plus page. The Google Plus page is a mechanism for the college to update members and fellows and the public indeed on activity at the college, but it's essentially one way. We have set up a community which you'll see on the right hand side of the Google Plus page when you visit it. The community allows two-way discussion. You still have to join it, it's free to do so, but once you've done that, you can then bring notices to our attention, so it becomes a two-way street, and hopefully that is much more educational. So if you have anything you'd like to bring to the table for future Journal Clubs, then don't be afraid to do so. But it's been a pleasure as always, and we'll sign off there. Thank you.
Okay, thanks very much.